Hi, everyone. Thank you for joining us for our second session of the day. I hope you enjoyed Becky's program, and I'm happy that you guys are back. My name is Haley. I work with PAMGMA. I'm proud to say I get to frequently work with our sponsors and vendors. PAMGMA is so grateful for the support of all of our sponsors, and I'm happy to introduce Stellar Health, the sponsor of our next session. Please welcome Tejas from Stellar, who will say a few words.
Hi, everyone. As Haley mentioned, my name is Tejas, and I currently work at Stellar Health on the business intelligence side. And my main focus is on both payer as well as provider partnerships. On the provider side, I work with practices across the range in terms of size as well as specialty. And so excited to give you a little bit of an overview of what we do as it pertains to this discussion. Um, Stellar is trying to solve this risk reward problem within value-based care. And one, we recognize that incentives are misaligned on the provider side in terms of what payers expect them to do. There's a lack of transparency for the things that are being done and how they're being rewarded. It is the entire care team, for one, that is helping in the success for providers in terms of VBC. So there's MAs, PMs, FOs, nurse practitioners that are all doing the work that are necessary, but are not being rewarded per our understanding. And these rewards are paid out 12 to 18 months after a given performance period, with very few dollars even reaching practice staff. So as a solution, what we've done is we've created a point of care platform that is one payer agnostic. We've broken down value-based care measures into granular actions that can be completed at the point of care by the entire care team. So it's a simple checklist of 4 or 5 things that can be done, whether it's persistent conditions in terms of diagnoses or quality actions like screenings. And I think what sets us apart is this incentive design. For every action that is completed, we pay out dollars that are pass-through dollars from the payer to the providers and their staff on a monthly basis to kind of solve for that transparency issues and give real-time credit for the work that providers are already doing. So if you'd like to learn more about Stellar or would like to be part of the Stellar program, feel free to reach out to me at Tejas, Tejas .singh at stellar.health, or you could also visit our website. Thank you and hope you enjoy the discussion today.
Thank you, Tejas, and thank you again to Stellar for being our sponsor of this session. I would now like to introduce our speakers for today's session. As the CEO of Archway Health, David Terry is a thought leader and frequent speaker on bundled payments and other payment reform initiatives. Throughout his nearly 30-year career in healthcare, Terry has been a senior executive and trusted strategic advisor for providers all along the care continuum. In these roles, he has led a variety of care and risk management initiatives, including negotiating payment contracts, developing risk-sharing models, and building the largest network of providers in the CMS bundled payment program. Terry holds an MBA from Harvard Business School and a BA from Columbia University. And Michael Phillips is a senior manager on the policy and solutions management team at Archway Health. Michael comes to Archway with 10 years of experience managing clinical quality improvement assurance projects in academic medical settings, primarily in the Mass General Brigham system, formerly Partners Healthcare. Thank you to Mike and Dave, and I will send it off to you guys.
Great, thanks, Haley, and thank you to you and your team at PMGMA for the invitation to present today, and thanks to Tejas and Michael Mang and the team at Stellar Health. We're thrilled to be here. So let me share my screen, and we'll get into the presentation. Okay, you see that? Okay, great, we're off and running. All right, so today we're going to talk about the accelerating shift to value-based care. I'll start us off here, and then Mike will jump in as we go. So Haley took care of introductions. The agenda for today, we're going to talk about what we're seeing as the drivers of the acceleration toward value-based care in the market. talk a bit about the overall value-based care model, and then we're going to do a deep dive into the Medicare direct contracting program, which kicked off with about 53 participants, 2 weeks, 53 participants in about 30 states across the country a few weeks ago. And then we'll leave some time at the end for Q&A. Please feel free to put your questions into the chat, and we'll sort through those and try to get to as many of those as we can. My name's Dave Terry, joined here by Mike Phillips. Thanks again for attending today. A bit about Archway. So we're based in Boston, founded in 2014. We're a value-based care company. The best part about Archway is our team. We've got an eclectic group of what I would call healthcare delivery and reimbursement experts. I would put Mike and myself in that category, and a bunch of folks who've been working in the delivery system and all different types of reimbursement models over the last 20 plus years. We've got terrific data scientists who spend a lot of time analyzing the impact of these value-based care programs, whether they're coming from Medicare and CMMI or from commercial contracts or Medicare Advantage plans or employers. We've got technologists who build technology tools to help manage care and risk. And we've got insurance experts and actuaries. We're focused mainly on providing stop-loss coverage for providers and employers who take healthcare risk. And so we use this data and expertise to really understand, what do these programs look like? How do they perform and behave? And which of these programs are right for specific providers, right? So as you know, there's an alphabet soup of various initiatives coming out of CMMI and different payers, whether it's the bundle payment for care improvement program or next gen ACO, MSSP ACO, or the direct contracting program. Our objective, and really what Mike's team leads, is to really understand these programs and then use our data and our data science team to model them and use our insurance partners to underwrite them. We are a qualified entity, thanks in large part to Mike's work in Medicare, which means we have access to 100% of the Medicare A, B, and D files. And we use that data to really, as I mentioned, understand how these programs work at a granular level. And then also we profile providers and understand how a provider would perform in a particular program. We also have about claims for about 35 million commercial beneficiaries across the country. We're partnered on the underwriting side. We're partnered with an A-rated insurance carrier. Talk about them in a moment, who finances essentially the insurance. We've been doing this, as I said, from 2014. We worked with dozens and dozens of providers over the years in all of these different programs, BPCI, oncology care model, all the different ACOs, Medicare Advantage risk programs, employer stop loss programs, and those types of things. So our partner is Coveris. You may know Coveris. They're the, I think, fourth or fifth largest medical malpractice liability carrier in the country. A-rated balance sheet, recently retained a seat at Lloyd's of London to continue to drive growth. We've been partnered with Coveris since 2015 and really enjoyed that partnership. They're terrific in working with us to innovate around how to develop products that can help providers get into these programs without feeling like they're taking too much risk. And so they've been a real thought partner with us in terms of how we develop these programs and underwrite them and get them out of the marketplace. And also, it's great working with someone who the provider community knows. Coveris has been covering professional liability for over 30 years, and great reputation and brand of the market, and a very sound balance sheet and position overall to take and share risk with us and with providers. So let me get into a bit on kind of what we're seeing that's driving this market. So at a very macro level, there's the biggest driver that we see is really the federal deficit. This is data that's pre-pandemic, but indicates that federal deficit continues to grow significantly. It's at unprecedented levels as a percent of GDP in our country today. And the biggest driver of the federal deficit is healthcare spending. And so this is one of the unique areas in today's landscape that seems to have consensus across administrations. Certainly, we saw the Obama administration addressing this, trying to address this through the Affordable Care Act. The Center for Medicare and Medicaid Innovation continued to push out lots of different value-based care programs in the Trump administration, and we continue to see them expanding and moving forward, and expect considerable growth coming from the Biden administration, mainly because, our view really at the federal level, we have no choice but to find ways to improve the value of the healthcare that's delivered and that the government is purchasing. I'd also say this is not just an issue at the federal level. Certainly states are under significant pressure now coming out of COVID to find ways to manage their budgets, and healthcare is often the biggest expense of a state government. And then employers, again, coming through this COVID-related recession, are increasingly focused on where they can reduce costs, and healthcare is a big expense for them as well. So as we see this happening, in 2019, CMS came out and said that their goal is to have 100% of Medicare providers participating in meaningful downside risk arrangements by 2025. That's for traditional fee-for-service Medicare and Medicare Advantage, and for 50% of providers to be in meaningful commercial and Medicaid downside risk arrangements. So, for us, right now we're at about 20 to 25% of providers participating in these programs in a meaningful downside way. And so, we see that that's about $1 trillion of risk shifting from government payers and commercial payers onto the provider market. And so massive change in how healthcare gets paid for, and massive change in how healthcare will be delivered, we think, for providers who are experiencing this shift from fee-for-service toward these different value-based arrangements. So we're going to skip over those slides. We'll come back to them. A couple other drivers are so another driver is increased provider demand for these programs. So as I mentioned, CMMI has continued from the Obama administration through the Trump administration into the Biden team to create more and more programs. So that to date they've created over 50 different initiatives that they've rolled out across the market. And as they've rolled out these programs, we've seen thousands of providers across the country participate at different levels. And that's really increasing provider capability, provider confidence, level of investment and infrastructure that folks have made in these programs. And it's also increased demand for as providers move away from fee-for-service into different types of payment models and get confidence and build infrastructure to do that. Providers we're talking to are hungry to find more ways to get into these programs. And that's a big driver that we see of growth in the marketplace. A second is certainly every provider we work with, and I would hazard to say just about every provider in the country, saw a significant dip in volume and revenue in the second quarter of this year due to COVID, and maybe other times throughout the year due to COVID. And that led to a real interest in finding ways to diversify revenue beyond fee-for-service. And we'll talk about the direct contracting program today. That has an upfront PMPM payment, prospective PMPM payment component to it. And other initiatives like the oncology care model and the kidney care choices program have upfront payment components to them that help providers diversify away from volume-based fee-for-service revenue sources. And then lastly, we're seeing a lot of activity in the public and private equity markets in terms of new entrants coming in, taking risk in different ways and having significant success. Oak Street is a primary care-based Medicare Advantage business focused on essentially taking global capitated payment for Medicare Advantage plans and managing full risk for complex Medicare populations. They went public last year. They're losing money, but their valuation is over $13 billion. Agilon is another company similar to Oak Street. They're expected to go public this year with significant fanfare. And some of these other businesses, Signify, Landmark, have also done quite well. And so these companies that are taking risk and managing care in different ways are getting a lot of attention from the public and private equity markets, and they're growing quite rapidly in different geographies across the country. And frankly, taking market share from other providers in their markets. Another driver here is what we're seeing in the regulatory environment. So you may have seen at the end of 2020, there were significant changes to the Stark and anti-kickback laws that really incentivize and create safe harbors that incentivize groups to take risk and allow them to manage their patients in different ways. And the more risk an organization takes, the more flexibility they have to partner with upstream and downstream providers. So, for example, in a risk arrangement in the new Stark regs, a hospital can pay a physician organization for seeing patients post-discharge, or they can pay for delivering using various lab tests or radiology tests, or managing care in different ways, which wasn't allowed previously, but really tries to move the market toward more collaboration and more sharing of dollars in ways that improve care and reduce costs. And so another way that the government is really driving this forward. Excuse me one second. I'm just gonna, well, these slides get moved around a little bit here. So those are some of the drivers. We want to talk a bit about the landscape and how these programs are designed. So there are really two different models for how value-based care programs are created. One is, and there's lots of different flavors. As I said, Medicare has come out with 50 different programs over the last several years. But the way we see it, they kind of break down into two models at the macro level. One would be an accountable care organization, a kind of population health approach, where beneficiaries attributed to primary care physicians, and then those primary care organizations are given the full budget to manage all of the care and costs of that population. And so responsible for thinking about specialty care, all the hospital services that are delivered, any post-acute care, readmissions, all those types of things. And so we see that in the NextGen ACO, the MSSP ACO, these Medicare Advantage subcap arrangements that I mentioned. And we at Archway and Coveris, we underwrite all these different programs and are familiar with how all these programs work, and have assessed them from a performance and data perspective. And the second model would be a bundle payment, which is really more specialty focused, right? So where typically there's a trigger event, could be a diagnosis or could be a hospitalization or a procedure, and then the specialist is in charge of managing all of the care, specialist or the specialist organization, for managing all of the care from the moment that event happens over a period of time. Could be 90 days. In the oncology care model, it's 6 months. And in most of the Medicare programs and the handful of commercial programs that are out there, in this scenario, the specialist is really responsible for everything. They're responsible, if it's an oncology case, they're responsible for the diagnosis, delivering and taking risk for the medications and readmission, hospitalizations, any readmissions, ER visits, those types of things. If it's a procedure, responsible for the procedure, the anesthesia, the operating room, and any readmissions or post-acute services that are provided to that patient during that episode of care. Then when you kind of break this down, there's a whole variety of different programs that different providers can participate in that fall into these categories. So there's options for hospitals and health systems. We certainly see them participating in ACOs and moving into the direct contracting program. We also see health systems participating in bundle payments like the BPCI Advanced and the oncology care model. We see primary care groups participating in mostly some sort of primary care attributed model. Could be a broad ACO like direct contracting. It could be a primary care cap like Primary Care First. And then specialty groups mostly participating in different types of bundle programs like BPCI Advanced or the end-stage renal program that's come out, Kidney Care Choices, the mandatory radiation oncology model that is in the works. So there's programs out there for any type of provider, but they typically do fall into these either ACO kind of primary care attribution model or a bundle model. And then, as I mentioned, there's also quite a few new entrants who are coming into these programs. And in terms of where CMS is headed, so I mentioned that there are over 50 different programs that they've developed, leading into where we are today. We've been partnering with CMMI since we started back in 2014. We have very good relationships there. We talk to them quite a bit. And then we also talk to other policymakers who are involved in these programs. And we see them evolving really kind of into what we call CMMI phase 2. And that there's several aspects to that evolution. First thing that we hear them talking about is really moving away from having so many programs to having fewer, bigger programs. And the reasons for that are it's hard to navigate overlap and kind of competing priorities across so many different programs, and they're trying to improve that aspect of what they've done, and then also create more clarity for assessing the impact that these programs are having once they get implemented. And so definitely see them moving toward much bigger programs but fewer programs. Certainly moving toward more up and downside risk. Studies have shown that really the most improvement and change comes when there's meaningful downside risk. And so they're moving away from upside only programs and really moving toward programs that have significantly more downside risk, and that comes with more upside opportunity. And Mike will talk about that in a moment. One model we really like is this idea of ACOs with bundles underneath, we call it, which is having the primary care physicians have global responsibility for the patients on their panel, but then also partner with specialists who are really good at what they do, who can, when a patient needs a bypass surgery or has cancer or needs a knee replacement, partner with specialists who can take on the total cost, the total process of managing patients through those episodes in collaboration with their primary care physicians. And we feel like that's just the best utilization of the expertise that exists in the market and sort of what these folks were trained to do, but shares that risk such that it's impractical, we think, for a primary care physician to be fully responsible for everything without really close collaborative partnerships with specialty providers in the continuum. And then the last thing is they're definitely talking about making more of these programs mandatory. And they've talked about certainly making the next version of the bundle payment program mandatory. They've talked about potentially creating a 90-day DRG model as opposed to just the DRG for when patients in the hospital. That would be consistent with the structure of the BPCI Advanced program. And they've talked about really, ultimately, what we think CMS is moving towards is they really want as many Medicare beneficiaries as possible in a managed program. And so most markets, Medicare Advantage is about 30 to 40% market share. And so those beneficiaries are in a managed plan. The next gen ACO, the direct contracting program, are a mechanism for CMS to move their fee-for-service beneficiaries into a program that's managed by their providers, as opposed to an MA program that's managed more by a plan. And so we certainly see that in the next 4 or 5 years, these ACO models and these bundle models move away from being voluntary and move toward being mandatory. Skipped around a little bit here, but Mike's going to talk a little bit about kind of the trajectory of these population health programs, more the ACOs, and where we are with in the trajectory of moving toward bigger programs and more significant risk. Mike?
Great. Thank you for the great introduction, Dave. And thank you everyone for the opportunity to speak today. To Dave's point, in order to really understand the mechanisms of global and professional direct contracting, we need to look at its lineage a bit. and it's most closely related to the Medicare shared savings programs and next generation ACO. So pictured here is a schema of sorts that compares the amount of prospective payment that an organization receives to the level of participant risk. And as you can see, there's sort of 3 points here at the lowest risk and the lowest amount of prospective payment up to the highest level of risk where direct contracting sits and the highest amount of prospective payment. So just as a broad overview of each of these, Medicare Shared Savings Program is the lowest risk relative to the other programs. I just really want to emphasize there that although it's the lowest risk, does not mean that it's insignificant risk. It's still a program primarily reliant on Medicare fee-for-service or fee-for-service payment mechanisms, so it's not really driving that transformation to prospective payments. It introduces a risk glide path, though, to organizations that begins at upside only, but then gently progresses into more downside risk, and I'll share more of that on the next slide. Savings and losses are constrained to a risk corridor, so it's not based on first dollar. You need to earn or lose a certain amount prior to sharing losses with Medicare. It is a voluntary program, but it is permanent as well. And by permanent, and why it's in quotes here, it's a legislated program. So any changes or cancellations to the program need to be proposed and finalized through the Medicare rulemaking process. Sitting in the middle here is the Next Gen ACO program. This is a voluntary program, and it's not permanent. This is run by the Medicare Innovation, CMMI. And this was really the first program to begin introducing prospective payments or capitated arrangements to participants. And it really began upping the stakes a bit on the amount of risk that these organizations were taking on. So organizations were responsible for first dollar risk at either 80% or 100% of shared savings and shared losses. They had a little bit of leeway given to them related to the cap, so they could only lose or gain as much as 15% of the overall benchmark. This is sunsetting this year. It's currently meant to end in December later this year. And that transitions nicely into global and professional direct contracting, which in many ways is viewed as the next step for next generation ACO. Again, we're looking at a retrospective settlement. There is still some reliance on fee-for-service, but the biggest difference in why it's introducing a lot more risk into organizations is direct contracting entities, as they're called, are required to take on capitated payments in order to manage the care that they're providing to their aligned beneficiaries. This is first dollar risk for 50 or 100% of shared savings and shared losses, but unlike Next Gen ACO, there's no cap, so there's no maximum that a direct contracting entity can gain or lose. Again, this is a voluntary program. It's run by CMMI, the Center for Medicare and Medicaid Innovation, and it began just about 2 weeks ago on April 1st, 2021. Dave, if you can advance the slide, please.
Sure. Yeah. Let me just say one thing about direct contracting. There has been some confusion in the market as to whether Medicare is still committed to this program. Last week, so as Mike said, the program, there are about 53 providers across the country that started 2 weeks ago in the program. So it's off and running. There'll be another, we think, 30 or 40 providers that'll start in the program on January 1st of 22. One thing CMS did announce last week is that they've pushed off the next open enrollment period for new providers to apply to get into the program. We expect that window to reopen either late this year or early next year for new applicants to apply to get in. So it's off and running, but the most recent open window, or the next open window date is not yet determined.
Yeah, that's absolutely correct. Thanks for that addition. So this is meant, and I want to be mindful of time, and we really want to get into the mechanisms of direct contracting. But in order to really appreciate that, I think that we need to take a slightly deeper dive into Medicare Shared Savings and Next Gen ACO. So again, MSSP is a permanent program, meaning that's legislated. And as I said before, any changes need to go through the Medicare rulemaking process. Participants sign 5-year contracts. Even though early termination is permitted, the expectation is that you're committing for a longer period of time. And participants into MSSP take on increasing risk, as is demonstrated in this slide here. If you enter in at level A of the basic track, you're not really taking on any downside risk, which doesn't begin until level C. And that gradually increases as a maximum percent of your benchmark up until level E. There's also the enhanced track, which is a separate contracting period that places organizations at risk of 75% of the benchmark. So really making that leap into a higher risk sharing arrangement. It's important to recognize that the program is still fee for service. Therefore, it's not as transformative as NextGen was and as direct contracting is. However, it's important to highlight here that the basic E and enhanced tracks qualify as an advanced APM, which is very relevant for participant providers and their MIPS requirements. And like most Medicare programs, it gives participants access to an incredible wealth of data that they can really use to help with their operations and driving care improvement. Next slide, Dave. Thank you. So a lot of what I just said for Medicare Shared Savings Program can be said for NextGen as well. Like MSSP, participants are getting a wide access to a wealth of data. The program qualifies an advanced APM, which is highly attractive to participant providers here. Organizations are put at risk for the full complement of Medicare A and B services. But I'll highlight a couple main changes here, which really set the stage well for direct contracting, in that it's a simpler risk sharing structure, as I alluded to before. You have partial or full risk. Your sharing rate's 80% or 100% with some safety installed on the cap. It's not as complicated as MSSP risk, which is really meant for an introduction into risk taking for organizations. And what was really transformative about this, as I mentioned previously, is participants were given the option of limited upfront capitated payments that can support infrastructure and maintain cash flow throughout the year. So those organizations that felt like they were truly advanced and could take on that prospective risk and constrain their costs during the year could benefit from those capitated payments. And CMMI, Medicare, they're relying on that same level of commitment and innovation as they set forward into direct contracting. David, next slide, please. So we'll start our deep dive into here and hopefully can highlight here how this is truly a great progression. So let's talk first about the risk options in direct contracting and break down its basic structure. So again, similar to NextGen, 2 risk options are available to participants. You have your professional track, which will put direct contracting entities at risk for 50% of shared losses and shared savings. The global track puts participants at risk of 100% of shared savings or shared losses on a discounted benchmark. So the discounted benchmark is relevant because in order to produce those savings to share in it, you need to cross a threshold before you even begin making savings. Medicare will discount your benchmark by 2% in the first year, up to 5% by the 5th year of the program. Regardless of the risk sharing option that a participant chooses, they do need to maintain a capitated payment arrangement that's really either tied to specialty care or primary care. And we'll get a little bit more into the mechanism of that in a future slide. I'd be remiss not to mention a third track that was going to be handled through a separate application process, the geographic model. And this was effectively a regional model where an entity would be responsible for a very large number of beneficiaries within that area, 30,000 plus. This has currently been suspended by the Biden administration while they evaluate it and see its suitability for implementation. We expect to receive updates on this model throughout the year. But let's emphasize a little of focusing on global and professional here, just the key points. So it's an accountable care structure that specializes in providing care to fee-for-service beneficiaries over a 5-year duration in this voluntary program. Beneficiaries are primarily assigned through primary care providers, but can also be aligned through certain specialties or voluntarily. And the benchmarks that direct contracting entities should be relatively familiar to organizations entering into the program. They're based on a mix of historical performance as well as a modified Medicare Advantage rate book, effectively adds hospice back in, that accounts for regional or county rates. So the benchmark is a convenient blend of historical performance plus a predictable regional rate, which sets an achievable target for direct contracting entities entering into the program. Dave, next slide, please. So now that we understand the structure a little bit, we can see that's actually relatively enticing to many organizations. As Dave mentioned previously, 53 entities of varying levels of experience and risk-sharing arrangements went live on April 1st, about 2 weeks ago. And something really striking from this slide here is there's really only 7 states that do not have some overlap with a direct contracting entity. Important to understand, direct contracting entities can provide services in multiple states. In this case, it's showing the density of direct contracting entities by state, with the highest density being in Florida, with 16 direct contracting entities providing services to beneficiaries in those areas. So this is a great sign that says that providers are eager to take on more risk and to take on a transformative payment model that can drive change in healthcare. And we're very encouraged by this. And as Dave mentioned, given recent changes to an expected cohort 2 and the application period for that, we still do expect potentially 30 or 40 additional direct contracting entities to join into the program on a 1/1/22 start date, and perhaps additional entities in future open windows past that. Next slide, please. So how is the program structured? Well, starting at the top, principally the contract is between Medicare and the direct contracting entity. Medicare has the prime responsibility of setting benchmarks and the per member per month amounts that are paid directly to the DCE. The DCE is responsible for their risk selection, their quality performance, as well as being responsible to pay back any shared losses. On the flip side of that, they're entitled to share in savings from Medicare. Working our way down this schema here, all direct contracting entities are required to have participant providers, which are primarily consist of primary care providers, but can include select other specialties. Participant providers must be paid by the direct contracting entity. But on the flip side, there's also preferred providers where we expect the specialty dollars to reside in, as is indicated here between cardiac care, musculoskeletal, cancer care. This list is representative, but clearly not all inclusive. And whereas participant providers determine beneficiary alignment, the preferred providers do not, but it is within a direct contracted entity's best interest to contract and enter into downstream arrangements with these preferred providers. So basically, this is a long way of saying is if you're in a specialty practice and there's a direct contracting entity in your area and you haven't been approached yet to enter into a preferred provider relationship, you will be. Because as Dave alluded to earlier, a lot of healthcare spend lives in the specialty area. So in order to succeed, direct contracting entities need to engage with specialty providers, create downstream value-based arrangements in order to help constrain expenditures overall and establish these preferred provider networks to best serve beneficiaries. Dave, next slide, please. Next 2 slides, I want to be mindful of time because I'm going to pass it on to Dave, but I just want to make a couple other points that are going to be key to the overall success of the program. First is the quality strategy that they're using in the program. CMS is premiering a small set of actionable outcomes-based measures. So in the first year, they're only going to have 2 quality measures that apply to all direct contracting entities. And these are all condition readmissions and unplanned admissions for patients with multiple chronic conditions. In the second year, they're proposing to expand this to timely follow-up after acute exacerbations and some form of direct contracting specific CAHPS surveys. we're heartened or we're encouraged by CMS's strategy. This is really a step away from process-based measures into outcomes-based measures, which really allows practitioners participating in this program the ability to practice at the top of their license and focus on improving on the outcomes that are most meaningful to their practices. Next slide here, Dave. And lastly here, I just want to emphasize that there's a number of different waivers and in-kind benefits that direct contracting entities can take advantage of. If you participate in value-based care initiatives before, care management enhancements should be familiar. These include things like 3-day SNF waivers, telehealth expansions, waivers for home visits to disburdened providers. And these are essential for just that, disburdened providers to allow them to be more flexible in the care they're providing and ensure that patients can stick to their care plans. This is the same for the in-kind benefits, where you can set up things like reward programs for beneficiaries to encourage them to stick to care plans, such as gift cards for smoking cessation programs when a beneficiary has successfully either initiated a smoking cessation program or achieved smoking cessation. So that is very much the high flyover of direct contracting structure. It's an incredibly robust and complex program. I'm going to pass it back to Dave now, who's going to speak a little bit more of the benefit of the program, particularly at the provider level.
Thanks, Mike. Yeah, one thing I'd add to this, to comment on this slide, there's also provisions for giving copays for beneficiaries for certain types of services, right? So we work with a lot of cardiologists, and cardiac rehab is something that can be quite effective to help patients recover, but the copay is often a barrier, and so there's options to give copays for those types of things, options to give copays for like a remote patient monitoring service to track patients who are in some sort of acute event or have a chronic illness. And so it just creates a lot more flexibility for how providers can engage with their patients that are in the program. So Mike went over the basic details of the program. Our view, as I mentioned, we've been in pretty much all of the Medicare programs, or certainly been in many of them and studied all of them since CMMI got going. And we think this direct contracting program is the biggest and most impactful that they've created yet. And there are really 3 game-changing attributes that distinguish this program from others that have been rolled out so far. And the first is it's a prospective payment model. So you get your money up front. It's not, and it doesn't rely on the fee-for-service chassis. And so getting dollars up front enables providers to have a lot more flexibility in terms of how they pay themselves and how they incentivize the doctors and providers on their team, as well as how they reimburse downstream providers like specialists and hospitals and those types of things. And it gives the ability to enter into new types of reimbursement models at the local level, as well as taking some of those dollars and investing them in care management infrastructure and programs that the fee-for-service or retrospective reconciliation doesn't offer. The second is it's not a shared savings program. And that's important because in MSSP and NextGen, a portion of the savings go back to CMS, and just about most programs that they've created, a portion of the savings go back to CMS. And it just makes it hard to make significant investments when you get your money late in the retrospective model, and you have to give part of the savings back to Medicare. It makes it hard to make those investments. In this program, providers who are participating get all the fruits of their labor if they do well. Now, the corollary to that is it's not shared downside. And so, and that's really why one of the reasons we've developed these stop-loss products is to help providers get into these programs without taking too much risk and having the access to the full upside. And the third aspect, which is really unique and we think very interesting in this program, is how it incentivizes primary care providers to enter into collaborative value-based arrangements with specialists. And so there are 2 aspects of this incentives. One, as Mike said, in order to be successful, we believe that partnering with high quality, high value specialists is important, because that's, patients spend money when they're sick and need the most care when they're sick, and they're often with specialists. And so making sure that the specialists in your network are really good at what they do and can do it for value total cost of care is very important. The other aspect of the incentive is that in order to get specialty dollars flowing into the top of the funnel as part of your PMPM payments, your prospective payments, you need to have those partnerships with your downstream specialists. So when the program starts, primary care dollars will flow prospectively, and as direct contracting entities enter into risk arrangements with specialists like cardiologists and oncologists and orthopods, those dollars will start to flow to the direct contracting entity prospectively. And that will really increase the flexibility and the capabilities of the direct contracting entity. And just by way of example, this is preliminary data, but the CMS really recommends that a direct contracting entity start with a minimum of 5,000 lives. There are mechanisms where you can start with fewer, but that's a number of program size that really resonates with us. On average, in many markets, the average PMPM ranges somewhere between $850 to $1,000 per member per month, depending on the risk score and the geography. That would be about a $51–52 million budget for a population of about 5,000 beneficiaries, and this is just for Medicare Part A and B. Doesn't include the Part D drugs. Roughly $40 to $50 PMPM, or $2.7 million, goes to primary care. And then, very interestingly, here's where the rest of the bulk of the dollars go from a budget perspective for Medicare beneficiaries. And you can see it will be essential for a strong direct contracting entity to have a really good relationships with the cardiovascular physicians in their community, and folks who care for people with diabetes and other chronic conditions, orthopedic surgeons, oncologists. And this is, frankly, I think the most exciting thing for us about the program is the way that it will facilitate much more collaboration around care delivery and reimbursement models between primary care and specialty care as we move in this direction. And I think that this also has a real potential to change market dynamics, because now folks will be much more discerning as to whom they're referring their patients for downstream specialty and hospital and post-acute care. Number of benefits to participants. One is certainly the opportunity to grow revenue, moving away from fee-for-service into a capitated, prospective payment model, improve cash flow for similar reasons. And we think those two things together create real opportunities to improve care, right? So the ability to invest that new revenue and that cash flow into improved care coordination, care management capabilities, engaging patients in different ways. And we've seen that in programs we participated in and providers we work with who've gotten into these programs. More control. So we do see this as a way for independent providers to stay independent, because it gives you more control over the data, your patient flow, and the dollars coming into your practices. Greater independence, certainly for the long run. And our view and our experience is healthcare reimbursement markets follow Medicare. And if Medicare starts moving in a certain direction in a big way, the rest commercial market and the Medicare Advantage market will follow. We've certainly seen that in other programs. And we think, given the size and scale of this program, we think this is really a early move into more capitated, significant structures that will, by getting into this program, help providers prepare for future programs that are coming from Medicare and from other payers. We've got a couple minutes left before we get to questions here, so let me just hit a couple key points. Number of keys to success here. This program, certainly the ability to transition from fee-for-service to capitation, segmenting patient populations for primary care. So really having a good understanding of who on your panels is well, and developing care protocols for them, who has specific chronic conditions, who has multiple chronic conditions, and providing different ways to treat patients in different categories, and having different teams of folks who who get really good at caring for your diabetic patients or your CHF patients. And then, as we mentioned, on the primary care side, having partnerships with really high quality, high value-based specialists who are good at what they do, will collaborate and communicate and provide the best care for your patients when they need those specialty services. On the specialty side, it's going to be essential for the specialist groups to have partnerships with primary care organizations in these programs. As Mike said, there's 53 that started 2 weeks ago. Understanding who those folks are in your market. There's a bunch in Philadelphia, we know, and who those folks in your market are doing this and reaching out to them to make sure that you're at the top of their list for referrals and partnering with them to manage their patients in a very proactive, quality-driven way. I'm going to flip over here. Just some other key, really, this is getting into kind of understanding who's in your market in terms of specialty providers and what, how good they are at what they do. We've got a lot of data around that. We spend a lot of time assessing the quality and costs of specialists in every category. And so understanding that is we think is a key to success. Understanding what your performance looks like on a risk basis and what you need to do to improve the chances of success. And then lastly, let me just hit on kind of how to participate. So as Mike said, you can be a participant provider, and that you can do that at any time if you've got direct contracting entities in your market that have gotten started. We do suggest that specialists certainly find out who in their market's doing this and reach out. You can be a preferred provider, which it means you don't necessarily are taking risk in partnership with a direct contracting entity, but you've got a close partnership with them. And then the third option is when the window opens back up, is consider becoming a direct contracting entity, and we expect that option to reopen either later this year or early next year. And just quickly in terms of timeline, as Mike said, performance year 1 started on April 1st. The participant providers who want to participate with existing DCEs starting next year, those would be executed late summer, early fall. And the next group will start on January 1st. And we think cohort 2 applications will be due sometime early next year. So that was a whirlwind. Haley, happy to take questions if any have come in here.
Yeah, I have kept an eye on the chat. I don't see any questions right now. So if anybody has any last minute questions that they want to pop in there for Mike and Dave, we have a few minutes here. I did want to remind everybody that the next session is going to begin in about 7 minutes at 1 p.m. If anybody has any follow-up questions, Janet asked, any thoughts on pharmacy costs?
Yeah, so Part D is not included in the risk aspects or of the PMPM payments for this program. But Part B drugs obviously are. And those are some of the most expensive drugs that are, newer, cancer drugs or gene therapies and those types of things. And so, yeah, we're very active in working with providers in a number of kind of alternative PBM organizations to help us proactively manage the effectiveness of high-cost drugs and also understand what alternatives might be available in certain circumstances. In some circumstances, in certain chemotherapies and gene therapies, there are really no options, but we certainly expect to see more proactive management of these drugs, and there are a number of organizations that have emerged to help with that.
Dave, if I could add to that as well, interestingly, CMS referenced Part D in the request for applications, the original request for applications for direct contracting, recognizing the growing costs and the growing share of costs for overall health expenditure. I think that there's an important trend emerging from CMI of trying to recognize how to get Part D involved in some of these innovation center programs that traditionally have not included it. So that's one thing that in the future you may see this involved. Another aspect to it in Part D is one could argue the halo effect of Part D, right? That an organization that is paying careful attention to Part D costs, trying to cut costs by biosimilars or generics, could benefit overall participation here because it reflects a commitment to quality improvement, cost containment, all the like. So that's a little bit of an end around way and a little bit of a reach in some capacities, but I do think that there is a correlation there. Another aspect, and just talking a little bit about the data that direct contracting entities receive, is as part of the claims line feeds they get, they actually do receive Part D data, so they can monitor their Part D performance, even though it's not going to affect performance year experience. So that's just one example of the benefit of actively monitoring Part D, and also the benefit of participating in these programs. The wealth of data you get, you're not getting Part D data otherwise.
Great, thank you both.
And I guess I'd add a couple other comments, Haley, just generally. So as folks are thinking about this program or pursuing this program, there are a number of kind of capabilities and services that folks will need to either provide or contract for. And many of these, we've developed or partnering with other DCEs around. So we do work with many DCEs. Some of them we're partnering with to help providers get into the program. We're underwriting many of the folks that started in April. So there's certainly financial partnerships that are key to success. Basic MSO services. So direct contracting entities will need to pay claims. And so, we partnered with a TPA to pay claims in kind of a traditional fee-for-service way, but we're also developing mechanisms to pay claims, pay for performance models and bundle models and carve-outs for certain types of specialty care. We think that's essential for success, is really coming up with different ways to work with specialists and downstream providers and pay them differently based on value-based models. We mentioned data, so we spent a lot of time. First question any DCE or participant in a DCE should ask is, what's my opportunity for improvement and for earning savings, and what are my risks? And so we built a model to kind of assess that for anybody who's thinking about participating in the program. Care management services. So I mentioned patient segmentation and really thinking about how to manage, in this coming out of COVID here with so much positive experience in telehealth, how will we use telehealth to manage different populations? How will we care for our Medicare patients who are well? Annual wellness visits is super important. Remote patient monitoring programs are important. And then programs around chronic care, patients with different chronic diseases, either managed by primary care practices or even better, we think, managed in partnership with select specialists. And then this idea of partnering with being very discerning about who your specialty partners are and their ability to provide high quality services to your beneficiaries and to get access to information and to appointments and to what's happening with patients that you refer to them. And lastly is the risk financing. So this is 100% upside, 100% downside program. And so the ability to take that risk and be confident that you're not overreaching and kind of having the right partner on the risk financing side.
Great. Thanks, Dave. Thanks, Mike. I do want to give everybody a minute to get over to our next session. So I appreciate you both today. I thank you for joining us. Again, thank you to our sponsor, Stellar Health. And thank you all for attending and chiming in and participating. Really appreciate it. I hope everybody enjoys their next session. Thanks, guys.
Thanks, folks. Thanks, Haley.